Welcome to another episode of Fresh Natural Live. It's Monday evening, and happy Juneteenth to all of you and all of our listeners. I hope you had a great weekend, and I hope your Monday's going well as usual. And as usual, we have a great show for you tonight. We're going to be talking about peripheral arterial disease. Many of you may be aware of that. If you have relatives who are smokers, who have coronary heart disease, or who have diabetes, you may be aware of issues related to peripheral arterial disease. Anyone who's had amputations, who've had lower extremity vascular surgery, likely have had it due to peripheral arterial disease. So we have a great show. I'm going to review a New England Journal article that gives an overview of this. There's a little case presentation that we'll discuss. And so I'll talk about some of the basic science and what's discussed in the medical literature. We'll then take a break, and then I'll come back, and myself and the panelists will give our take on things. I'll share my thoughts in terms of how I manage patients with peripheral arterial disease. It's a little bit different than what's in the medical literature, but I think you'll find it quite interesting. So sit back and relax. We have a great show for you tonight. Okay, welcome back. Welcome back. As I said, we have a great show tonight. We're going to be talking about peripheral arterial disease. However, first, I'd like to welcome my friends and colleagues. We'll start with Dr. Pamela Atkins. Hello, Dr. Atkins. How are you doing?
Hi, good to be here. I'm doing well. Thank you.
So I imagine you guys treat a number of people with peripheral arterial disease. So I'll be looking forward to getting your take on things. And so it'll be interesting to see, how similar our different perspectives are. I want to next invite Isosa. How are you today, Isosa?
I'm good. I'm really good.
So which continent are you on this Monday?
I'm in the USA where it is Juneteenth.
So I was teasing you about that. Sosa's back and forth. She's got a special project I'm not going to mention going on in West Africa. So I'll just say that much and leave it alone. But anyway, welcome back to the show.
Thank you.
So that's Dr. Palmer. How are you today?
I'm fine.
So there's a rumor you have some special guests in town. So we might talk about that a little bit later. And of course, Dr. Floyd Atkins, how are you doing?
Doing wonderful.
Now, this whole issue of peripheral arterial disease, I'm sure, is something that you dealt with a lot in your practice because, the image that I shared on the show, the thumbnail image shows a person with a gangrenous foot, and so I'm sure you've seen a lot of those images or patients in your career. And so I'm sure you're going to have a lot to say about this tonight.
I'll share some horror stories with you later.
So anyway, so let's get started. We've got audience here tonight, and hello everyone. Good evening, JW, etc. Let me get into this. As I said, I want to start off by reviewing this article from New England Journal. It's on peripheral arterial disease. I apologize that I didn't share the link in the notes, but I will go and revise the notes. So for those of you who go back and look at the replay on this, you'll see the link to this article in the notes. But you can actually just look at this title and the sub-author's name and do a search on the peripheral arterial disease, New England Journal, and you'll be able to find it. But the New England Journal does a number. When they do the review, sometimes they'll do a case scenario. So here's a patient they talk about who's a 61-year-old woman with a 3-year history of discomfort to the right thigh on exertion. Now, I'll back up and say, exertional symptoms typically are vascular related. So if you have exertional chest discomfort or exertional shortness of breath, that could be related to coronary disease. If you have exertional limb discomfort, that could be related to peripheral vascular disease. So anytime you have a situation where exertion either brings on or exacerbates or makes worse symptoms such as discomfort or the like, you tend to think of a vascular problem, largely because with exertion, you're increasing a demand. So from the standpoint of coronary disease, when you exert yourself, you're increasing total body demand for oxygen, particularly, therefore, the heart has to work harder. And so its demand for oxygen increases rather. And so when you exert yourself, the need for oxygen delivery to the arteries. Now, the coronary arteries are a little bit different than other vascular beds, I should say. The coronary myocardial tissue. With myocardial tissue, it extracts about 95% of oxygen from the blood that's delivered to it, compared to, say, in the periphery, it extracts about 75% of the blood. So, for instance, if you need more oxygen to the coronary arteries, there's only about a 5% amount of increase that you can do by just extracting more. But with the periphery, there's about a 25% hedge. So, for instance, if you need more oxygen in the periphery and say those arteries are blocked, you may be able to extract more. So maybe you extract from, say, 75% to 85 or 90%. But in the coronaries, you go from 95% to, say, 96, 97, but not much more. You probably can't extract that much more either. So the increase in oxygen delivery, or I should say the requirement or meeting the requirement for increase in oxygen needs for coronary or heart muscle tissue is more strictly tied to increasing flow. So if the arteries are blocked or not able to dilate for the heart, then you're more likely to have symptoms such as, chest discomfort or shortness of breath sooner than, say, for the periphery. Having said that, you can probably go longer with peripheral arterial disease without symptoms than you can with coronary disease without symptoms. Even though lots of people have coronary disease without symptoms, you theoretically can go longer with peripheral arterial disease because the tissue bed, muscles and the like, will simply extract more oxygen in the setting of a certain amount of disease. So this patient had 3 years history of discomfort to the right thigh. And so in theory, she may have had disease for much longer than 3 years. And that's kind of the point I want to make, with that little miniature dissertation. She had a history of coronary artery bypass. Now she's 61. She had coronary artery bypass after a heart attack, that's myocardial infarction, at the age of 55. And she had hyperlipidemia. So now she had bypass surgery, heart attack at 55. That's 6 years prior to, this presentation. And so, this coronary bypass, the coronary artery disease developed over decades. So it's pretty easy to say that she had probably significant, if not advanced coronary disease in her 20s or 30s. That wouldn't be too much of a stretch in her, and probably very likely had significant peripheral arterial disease around the same time. She was taking atorvastatin, 40 milligrams daily. She had a 50 pack year smoking history. So pack years, the number of years times the number of packs. So if she smoked 1 pack of cigarettes for 50 years, so maybe she smoked since she was 11 years old, then, that would be a 50 pack year. If she smoked 2 packs of cigarettes for 25 years, that'd be a 50 pack year smoking history. So she may have had maybe, 2 packs or 1.5 packs for maybe 30 plus years, something like that. But she smoked very significantly. At the time of presentation, she was on 8 cigarettes a day. That's a little less. I think there's a little less than half a pack. I think a pack is 20 cigarettes. I remember my dad was a smoker, and I think he smoked those Lucky Strikes. I think there were 20 cigarettes per pack. My familiarity is not from personal experience, but from, seeing my dad's cigarettes. I thought I'd point that out. Anyway, so blood pressure time wasn't too bad, 126/82. And then there was a bruit over the right femoral artery. A bruit is just a sound that you may hear go something like that. And whenever you have turbulence of flow, it causes a sound. So sometimes people have a murmur in the heart. So you hear that swishing sound where you shouldn't hear a swishing sound. So over an arterial bed or arterial body, we call it a bruit. Over the heart, we call it a murmur. So if you hear a swishing sound, that's the sound of turbulence, which in this case could be a sign that there's some narrowing in this artery at this point. So if you think of it this way, if you had water going through a hose or some kind of a tubular structure, and many people have done this, water coming out of a water hose, and the tip of the hose is coming out and it's flowing kind of smoothly. If you put your finger over it and create like a little stenosis, not only you cause some spattering of the flow, but you can make a little noise. And that's similar to what you would get with a stenosis, which we would hear a bruit in the case of an artery, or a murmur in case of a blood going through a stenotic valve in the heart. So this is what she had. So then, they posed this question: how would you evaluate and manage this case? And so then we go into this discussion on peripheral arterial disease. Now, as an overview, there's a big differential of peripheral arterial disease. We're going to be talking about what we call atherosclerotic disease, which is due to atherosclerotic plaque as a result of buildup of plaque. But people with vascular problems, such as for instance, lupus and other type of systemic vasculitides, can have peripheral vascular disease that can affect lower extremities, that can affect kidneys or the like. But that class of people we won't be talking about today. This patient clearly has the garden variety peripheral arterial disease related to atherosclerotic plaque, mostly built up due to metabolic problems, lifestyle in particular. There are two broad subtypes. They say proximal disease, which involves the iliac and femoral popliteal locations, is the distal part. So really above the knee and below the knee are really the two areas we talk about. It affects 8.5 million people in the U.S. and 200 million people worldwide. This number has probably grown in the last couple of decades due to the exportation of our poor lifestyle, and we'll talk about some of that toward the end. It's about $21 billion in costs in the U.S. alone. So some of the basic clinical points they make here: 200 million persons worldwide, 8.5 million in the United States. Now, we're going to talk about this later. Non-invasive vascular testing is the way to go with people with suspected peripheral vascular disease. And the treatment, the main goals of treatment. Now, here I want to highlight. So the goals of treatment are to maintain reduced cardiovascular risk, improve functional capacity, and they mentioned supervised exercise, increased walking distance. Now, cilostazol, which is an agent that can give some improvement in vascular function and some lack of platelet stickiness, is used, and they talk about this. And then they say if that doesn't work, conventional angiography and revascularization are the approaches. But I'm going to kind of go through some of this, and this is what's recommended. And then after the break, I'm going to kind of break down what my thoughts are and get some of my colleagues' approach to this as well. So the 1-year incidence of cardiovascular death and myocardial infarction and ischemic stroke was higher among persons with peripheral arterial disease than among those with coronary heart disease. Now, let me pause there. So, vascular disease is a systemic problem. And if we saw with the patient that was presented, she had bypass surgery at the age of 55, then she's more symptomatic now with peripheral arterial disease. I alluded to the fact earlier that you likely become more symptomatic with coronary disease sooner than maybe with peripheral arterial disease. However, some people can be asymptomatic or be symptomatic and not really pay attention to it with coronary disease for a long time and not present. But the point of emphasis here with this comment is that the real issue in terms of mortality with peripheral arterial disease is cardiovascular death. And so these people die from heart disease. Now, morbidity is linked to both cardiovascular issues as well as amputation. But peripheral arterial disease in and of itself, blocked arteries to the lower extremities, rarely kill people. When they come in with gangrenous, feet, rarely, unless, they refuse surgery, we can just, chop off the foot, amputate the leg, and these people, survive this. So from the standpoint of the peripheral arterial disease directly causing death in and of itself, we typically don't see that. But these people don't just have peripheral arterial disease, they have coronary disease. So anybody who's been diagnosed with peripheral arterial disease likely has significant coronary disease. Even if they don't have a significant narrowing, they may have an unstable plaque in the arteries of the heart. So the need for peripheral revascularization and amputation is about 1 in 4 over a period of 4 years. Ankle brachial index, which essentially we measure blood pressure in the lower extremity, the ankle, either posterior anterior tibial artery, and we compare that to the brachial arterial pressure, and we do a ratio. And if it's 1 to 1 or 1.5 to 1, it should be normal. But if it's less than 1, so in other words, if the systolic blood pressure in the ankle area is, say, less than 90% of the systolic blood pressure in the brachial area, then you likely have significant peripheral arterial disease, and then more workup or intervention needs to be done. So this ABI, or ankle brachial index, is an important test. We do it a lot in our patients who are at risk, particularly diabetics or people who are have a history of smoking or other things that make us suspicious. We look for that. So in other words, if you have an ABI less than 0.9 or 0.9 or less, you have more than twice the mortality. And the mortalities, again, is going to be for coronary heart disease compared to an ABI that's in the normal range. So just think of it, just 0.9 is just, 0.2 off in terms of, the low normal of normal range. I know there's an upper limit. If it's greater than 1.4 ABI, then that's probably a sign of arterial stiffness, and you probably need to measure the ankle toe index. And so a toe brachial index, because you may have calcified arteries that are very stiff if your ABI is like 1.5 or 1.6. And so that could be a sign of vascular disease as well. So how do we screen? Typically, you're going to start with a clinical suspicion. Someone who's a diabetic, age 50 or older is a diabetic. We actually screen, pretty much all of our diabetics will screen. So we're saying, can see advanced disease, people in their 30s and 40s with diabetes. So even though they say older than 50 with diabetes, and smokers with diabetes, we tend to even screen lower than this in my clinic. Person who are older than 65, you want to screen as well, because age the prevalence increase with age. The tricky part about this, you can have individuals who have pretty significant disease who are asymptomatic. And we've seen individuals with ABIs of 0.5 or 0.6, and they have no symptoms whatsoever of significance, but they're at increased risk of having a problem. They can have exertional discomfort, muscle cramps, similar to what the patient have. And then you have a subgroup of people who present with acute or chronic limb ischemia. And these individuals are people who, may have symptoms for a while and ignore it. And then what happens is maybe they get an injury to the foot or whatever the case is. Whenever you get an injury or a cut or something, there's an inflammatory process that occurs. And with that inflammatory process, you need to have adequate blood flow to that area. And adequate blood flow frequently means increased blood flow. So let's say you have your foot, there's no injury, there's no cut or anything like that, and you're going about your business, then your flow is important because, you're walking, there's a lot of, oxygen demand on your feet. And in fact, the reason why you probably need more flow to this lower extremity, remember the ABI needs to be greater than 1, ideally. And so that's because we walk on our feet and not on our hands. If we walked on our hands and not our feet, then the ABI can be less than 1. But there's already a increased demand on the lower extremities because we are walking on the lower extremity. There's a lot of vascular demand there compared to our arms. Maybe we walked on all fours, then it'd be equal. But long story short, if you increase that amount of demand with an infection, a cut in your foot, a cut in your toe, then that cut has to be healed. So even more flow is required. So if there's compromised circulation, those arteries are blocked, they're stiff, they're not able to dilate adequately, then they can't deliver more oxygen, oxygenated blood, and more immune cells to that site that's injured. So then what happens that if you get an infection or whatever, the infection or invading agent takes control because the immune system is like a freeway. You got a robbery going on, at a building, and the exit to that building is, let's say, off exit A, but the freeway's backed up because there's a block. They're doing construction, so there's only one lane. And so the police or fire that's trying to get to that building where there's a fire and there's somebody held hostage, the police can't get there. So because they're blocked, the flow to that area is impeded. So the same thing with your immune system, the circulation is impeded. The good guys can't get to that site. And so what happens, the bad guys take over. So the infection gets worse. And then you can get people with gangrene. So some people can present with this advanced disease because they've had either subclinical or asymptomatic or minimally symptomatic disease, and the disease gotten worse, and then they step on a nail or scrape their toe or get some injury, and then they present with an acute or chronic limb ischemia and gangrene or something of the like. Now this diagram here, it shows you what we look at when we do some non-invasive testing. Now you can get these waveforms when you're doing a Doppler. So we have a vascular tech that can do Doppler studies, so you can look at the arteries through echo, through a Doppler signal, as well as having a direct visualization with echo Doppler. And so we can look at the arteries, look at stenosis, look at flow, look at calcification in the arteries, and also do a Doppler waveform. Now on the left here, this is abnormal. This is reduced. We call this biphasic, but this is really not biphasic. I'll call this monophasic because you get one hump here. It's really not. This could be artifacts. It's a hump, and it's really one monophasic. On the left here, you see triphasic, and this is normal. You get up, down below the baseline, and back up again above the baseline. So you get one phase, two phase, three phase. That's what you should see. So you see triphasic, 1, 2, 3. So some people can go from a normal triphasic to a biphasic. So a biphasic would be up, down, below, and it would come up but not come back above. So it would come back up like that and level off. That would be biphasic. So the progression of these would be triphasic to biphasic to monophasic. Here you see monophasic and triphasic. And so these are the two extremes. And so they're showing it at different levels that's measured through the ABI. And so you can see by just looking at the waveform, you don't even have to look at the ABI measurements, but just by looking at the waveform, you can see the disease here. But they do give you the ABIs here. Okay, so they take the highest systolic pressure and then they measure it here. This is 1.01, 0.98, 1.02, and 0.99 on the DP. And so compared to 0.55 on this side in the dorsalis pedis, and posterior tibial is 0.56. Here you got 0.56 and then 0.58. So here's disease side on this leg compared to pretty much normal. This might be somewhere close to borderline, but you round it up to 1.0. So pretty much low normal to borderline. So this is advanced disease, but notice that even though these numbers are kind of barely in the normal range, the true normal you look at is 1.11 to 1.40. So there's some disease in this leg, and it's not unusual. It would be, even though you have triphasic waveform, but it's probably very, very early stage compared to advanced disease here. So non-invasive testing, ABIs, as I mentioned, and let me just sort of magnify this and share this part here a little bit more. So as we talked about, from 1 to 1.3, values of 0.91 to 0.99 are borderline. So we saw on that left leg, it was borderline, even though it had triphasic waveforms. The ABI greater than 1.4 could be due to poorly compressible arteries. So you may want to do a total brachial index, as I mentioned earlier. Disease, they kind of break it down to mild, moderate, severe. Less than or equal to 0.9, and then you go from less than 0.70 to less than 0.5, and then less than 0.5 to less than 0.125. What we do is we do serial measurements. So, for instance, you may have a patient who's, say, living in this range here, and maybe you're doing your therapies and lifestyle things. And I've had patients who come in, and they're normally like a 0.63, and then they'll call us, look, I'm having some tingling and some pain in my leg. We come in and do an ABI, and let's say, 2 months ago it was a 0.65, and all of a sudden it's a 0.35. And I've had patients like this, and right then and there, I'll send them to the hospital. We'll start them on intravenous heparin and some other things, and do an arteriogram and make a decision in terms of what to do from there. But you can go from moderate to severe, or even mild to moderate in a short period of time. So it's not only the amount of severity, but the delta. So if you go from normal to mild in about a few weeks with symptoms, then that's a rapid progression. Or mild to moderate, it's a rapid progression. So sometimes, one person with a 0.65 may be treated differently than another person with a 0.65, depending on the clinical scenario. So if they went from a 0.9, a month ago, now they're 0.65, and with new symptoms, then I'm putting them in the hospital. As opposed to if they're 0.68, 6 months ago, they're 0.65 now, nothing's changed. Well, then I'm going to continue to encourage that person to make lifestyle changes and do other things that we're doing, which we'll talk about later. Disease location, proximal, distal, and proximal and distal could be, in both multi-levels. And most times we see a lot of people with multi-levels. Functional capacity, pain-free walking distance, maximum. Some people are just limited. And oftentimes these people who have bad peripheral vascular disease and their functional status is limited by the peripheral vascular disease, that could be masking significant coronary disease. So we have a patient coming in and they have bad peripheral vascular disease, and maybe they, have some ischemia to the toe, et cetera. They may need surgery for these disease. However, the same person can have a left main coronary artery disease, and you're going to be recommending for vascular procedures. These vascular procedures are probably the most, some of the highest risk surgical procedures in the setting of people with coronary disease. So oftentimes it can be tricky with these patients in the setting where they have bad, claudication. So I don't walk very much. Well, okay, you don't walk much, but then you may have angina that we're not seeing because you're not active because of the peripheral vascular disease limits your activity level. Tissue oxygenation, I've used this before in patients in the hospital. These are people with severe peripheral vascular disease, and we do what's called transcutaneous oximetry. And these are people we're trying to evaluate. In most cases, when I've used it, we're trying to evaluate whether they're candidates for hyperbaric oxygen therapy. These patients do well with hyperbaric oxygen therapy if they have some evidence of flow or oxygen delivery, so that shows some level of reversibility there. Oftentimes, it requires revascularization and hyperbaric oxygen therapy as concomitant treatments. And then, of course, concomitant atherosclerotic vascular disease. They can have, subclavian artery disease or carotid artery disease or coronary disease. And frequently, these patients have all of the above. And so this is something that you want to be aware of in terms of evaluating these patients and thinking about these patients. As alluded to earlier, conventional coronary angiography is what's done. We've had patients where we had to send to the hospital emergently do angiography. There's a patient I presented in one of our talks several months ago who had an embolus to an artery. He also had peripheral arterial disease, but he had cardiomyopathy due to amyloid and had some atrial arrhythmias, and that resulted in embolization. He had to have emergency surgery. So these patients can have a lot of comorbid conditions, and the management can be very complex in terms of getting them out of one. And so they may have to have emergency vascular surgery, which is a high-risk surgery in the setting of, say, heart failure, cardiac arrhythmia, or coronary disease. And so how you manage these patients is really important from the global standpoint. And I'll share some thoughts with that later. CT and MRI are also diagnostic options for patients when it's not as urgent in terms of maybe needing urgent therapy. And as alluded to earlier, the main goals is reducing risk of adverse cardiovascular outcomes. Remember, the way these patients die is due to cardiovascular events, heart attack, in some cases stroke, but heart attack, stroke, sudden death. The peripheral arterial disease, the lower extremities, typically lead to morbidity problems, most related to amputations. Rarely do people die from this, die from gangrene, because by the time they get gangrene, they rush to a hospital. Most hospitals can do amputations and give antibiotics. But you want to try to prevent that. And so you want to preserve limb viability. If they have, toe ischemia, infarct, you can amputate the toe and hopefully not, have to amputate farther up. So they talk a little bit about treatment beyond surgery, hyperlipidemia, managing surgery. So in this article, they talked about two studies, well, actually one study in a registry data. The study was called Heart Protection Study, and the subgroup of patients that took simvastatin, they didn't mention the dose here. I'd have to look that up, but I would imagine it's probably simvastatin at least 40, probably simvastatin 40 or 80 milligrams, because you have to have an intense dose. They saw a 25% reduction in the treatment group, and this is a reduction in cardiovascular events compared to placebo, and that was over a 5-year period of time. There's a large registry study that was done, and I'm going to go through that algorithm in just a minute, of patients with peripheral arterial disease who were taking statins, and they had an 18% lower rate of patients, 18% need for revascularization and amputation in the patients on the statin. So there's evidence that you can reduce morbidity and mortality, or primarily morbidity, in the patient with statins and peripheral arterial disease. Now, when you look at this treatment algorithms, these things are kind of handy. I may follow this loosely, not so much. A resting ABI 0.91 to 1.4. Administer exercise tests. So sometimes you can have a normal resting ABI, and then you do an exercise ABI. And if it drops in the abnormal range, i.e. yes, and is symptomatic, then you take them over to this category here. So at rest, they may not have problems, but if they're symptomatic and like claudication, pain, or whatever, and it drops to 0.9, then that shows that they have more advanced disease, than you know. If they're not, then you're going to treat them with cardiovascular risk factors. I'm going to go to this in a minute. If it remains normal with exercise, then you go to other potential causes of leg discomfort. Sometimes people can have neuropathies. They can have arthritic conditions. But even neuropathies and arthritis can be due to microcirculation. We looked at our discussion on the BEMA therapy at the microvascular disease. Can result in tissue discomfort. And so you may not have the same clinical syndrome that you have with claudication, which is large vessel disease, but microvascular disease, which can then affect nerves and collagen tissue, because all tissue needs blood flow. And so even though you're looking for other causes, you may say, well, this is neuropathic, or this is due to inflammatory disease of the joint and musculoskeletal system, that too could still be microvascular disease. But we'll talk about that in the other, in part 2. So resting ABI from 0.5 to 0.9 is sort of mild, moderate, and severe, or ABI resting greater than 1.4. This is like moderate and severe, and this is mild. And this could be due to a stiff or calcified artery. they say measure toe brachial index. If that's abnormal, you take it down this whole management disease. So if it's mild, administer exercise tests to assess functional capacity. If it's moderate to severe, perform transcutaneous oximetry is what they recommend. And then you take it down this treatment, reduce cardiovascular risk, high intensity statin, treatment of hypertension and diabetes, smoking cessation, antiplatelets, aspirin, or clopidogrel. Clopidogrel was found, I think later on we'll mention this in an article, clopidogrel was found to have better efficacy than aspirin. You want to improve functional capacity, supervised exercise. Cilostazol also it reduces symptoms, allows you to exercise more. Revascularization if no response to exercise medication. Treat coexisting conditions, follow up, assess adherence to lifestyle change. Lifestyle. There we go. And drugs, and monitor for stent or graft patency in patients who've undergone revascularization. So that's a common approach. Notice we get a little mention of lifestyle there. We're going to talk about that a little bit more. Those you probably know what I'm going to get at. Hypertension, they don't have any recommendation of one type of blood pressure medication over another. However, there was one study that showed angiotensin receptor blockers work well in diabetics and overall improvement of their morbidity and mortality. Diabetes itself, you want to control the diabetes to improve microvascular disease and neuropathy, and we're going to talk about that more. Smoking cessation. This patient in the presentation had a history of smoking and continued to smoke, so you want to try to stop them from smoking. It's amazing to continue to smoke even after having a heart attack and bypass surgery. You don't treat them with warfarin or Coumadin. That's not indicated here. And here's where we talked about aspirin. Did not have effect on people with ABI less than 0.95. Clopidogrel was more effective than aspirin. This drug, Verapazar, is an antiplatelet. And by the way, for arterial disease, you go with antiplatelets. People with venous hypercoagulability, you go with anticoagulants such as warfarin and some of the novel anticoagulant agents. The exception, which is not mentioned in this article, is Xarelto, which is a factor 10 inhibitor. It's an anticoagulant agent, and at low doses, Xarelto has been found to be beneficial in people with peripheral vascular disease, and it was shown to reduce overall morbidity and mortality. And when they looked at the mortality benefit in that group, a large percentage of people had a reduction in stroke. Now, we know that these anticoagulants are associated with reduction in stroke with people with atrial fibrillation. And so, in fact, I was on one of the faculty panel before the drug was released. And so we had a discussion. They get some thought leaders in the community to talk about this. And one of the questions we raised in that study is that how well did they screen for atrial fibrillation? But then one of my colleagues said something I thought was pretty interesting, is that there could be an antithrombin effect that has some overall impact on vascular well-being, because people with atrial fibrillation who have stroke, they don't have stroke just by having atrial fibrillation alone. People with lone atrial fibrillation, in fact, we're going to talk about atrial fibrillation next week, but with lone atrial fibrillation, you don't give anticoagulant therapy because there's no benefit for anticoagulation, no increased risk of stroke. You have to have atrial fibrillation plus other things: vascular disease, diabetes, hypertension, female gender, previous stroke, etc. And then we give you a point system, and then the more points you have, the higher chance you have a stroke, then you anticoagulate those patients. So we know that people who have atrial fibrillation or at risk for stroke have other things that increase vascular, that have an impairment on vascular health, i.e. lifestyle things or other comorbidities that impairs vascular health that predispose to stroke. So this Xarelto probably have some benefit on vascular health through its mechanism of being a thrombin inhibitor. So that's a little bit more in depth for this conversation, but they should have at least mentioned it in this review article, and they didn't. I don't know why, but anyway, it was a pretty recent review article. So anyway, supervised exercise, a program that incorporates walking at least 3 times a week. I'm all for exercise. I can't Cilostazol is a phosphodiesterase inhibitor with antiplatelet and vasodilatory properties. So it does have some benefits in terms of vasodilatory properties and antiplatelet properties. And it's been associated to improve walking distance. And so that drug is being used. Revascularization primarily is indicated from the standpoint of limiting symptoms. So if you have somebody with real bad claudication, you've done all these things, and they still have symptoms, they're saying that you can then do revascularization in that situation. Most commonly, what I see is a patient who are more in an acute or subacute setting where you have to revascularize to save the limb. So for limb salvage, that could be in the setting of, gangrene or urine infection where you're trying to prevent amputation, or in the case of the patient I presented not too long ago, the gentleman who had an embolization, had an acute, shut off of blood flow. We had to hurry up and revascularize to prevent loss of limb in that setting. And so, that's the situation. Those are the common areas where you want to revascularize. Here's some endovascular procedures that are typically done. So just looking at the anatomy, you have the common iliac artery, the internal iliac. Some of the more important ones is the common femoral. You have the profundus femoris artery. The patient just recently had a stent placed in the proximal profundus femoris artery. You have the superficial femoral artery. This is an embolization that other patient I presented. The popliteal arteries around the knee, and then infrapopliteal arteries. You have the anterior tibial, the tibial perineal, then the perineal artery. Then you have the posterior tibial artery that comes off, and it gives collateral circulation with the anterior tibial in the foot with associated branches. So more proximally, you can do balloon angioplasty and or stent. As you work your way down, again, you still have the option of stent and balloon angioplasty. Sometimes you have to do atherectomy in the setting of calcification buildup. And distally, frequently they use either drug-coated balloon angioplasty or different drug-eluting stents or covered stents are often options as well. So in conclusion, so they discussed this patient that we talked about. So this patient in the vignette, so she should have undergone non-invasive arterial evaluation in the ABI. Had it been less than 0.9, which I'm sure it likely would have been, she'd have been a good candidate for more intervention. I'll talk about my thoughts after the break. She should be counseling for smoking reduction. Regardless of what the ABI shows, she needs to stop smoking. They would recommend initiating cilostazol 100 milligrams twice a day. I have a different take on that. They also recommend increasing the atorvastatin to 80 milligrams daily. I have a different take on that. And if they said if her symptoms continue to limit her activity, they would recommend angiography and revascularization. An endovascular approach would be the ideal approach to start with if the anatomy allowed for it. So that's the article, and that's their take on things. I'm going to, I guess, render a second opinion, as they say, as I'm often asked to do by my patients who come from different parts of wherever. So why don't we take a break here? I'm sure you all are tired of hearing me talk. So we'll take a break, and then we will come back after the intermission, after you've got a few seconds of not hearing me talk, to hear me talk again. But we'll all talk. Anyway, we'll take a break. Okay, we are back. And so I'm not going to belabor the point too much. I'm going to give a quick take on things, and I'm going to open the floor to discussions. And because, again, what's sorely missing from this take on things is really an aggressive lifestyle approach. And here's a patient who's had long-standing disease, and I alluded to very early on, that her disease probably started in her 20s and 30s. This is not an overnight phenomenon. And so her condition is not due to a deficiency of colostopol or a deficiency of atorvastatin or the like. It's a metabolic disease that's related to what she's doing inside of her body. And so what I want to do is kind of give my take on what I would do with this patient in the setting of peripheral arterial disease. But before I go on, I want to, again, welcome you all to Fresh Natural Live. Give us a thumbs up if you haven't had a chance to. I know some of you have. Show us some love in the chat. But if you listen to the recording, also give us a thumbs up, because I think this is information that should be shared with the audience. And if you haven't had a time to subscribe, please subscribe and hit the notification bell so you can get notification on future important presentations like this. And of course, share it with anyone who you think will benefit. So long story short, this person needs to be started on an aggressive lifestyle intervention. So she comes into the office with this presentation, the symptoms, the history of coronary disease, etc. On day one, I'd immediately do an extensive number of tests. I would check her ABI. We would also check inflammatory markers for blood. I'll check ultrasensitive troponin and the like. And so we would do all of these things. I would sit down with her and tell her, point blank, you're young, you're 61 years young. However, you're at risk for having your legs chopped off and having another heart attack. I'll be just that blunt. And we need to make changes right away. This is a 911 situation in my standpoint. And the 911 situation is one from a lifestyle intervention. So with this patient, we would do a battery of tests off the start. I would simply convey to her the importance of making aggressive lifestyle changes. And then I would talk to her about the approaches we use, how we can work with her, and the intensity of the therapy that she's going to need. So, and let's assume that she's amenable to that. Then we would schedule her for a follow-up appointment in just 1 or 2 weeks. I wouldn't say take this drug and come back in 3 months. No. She comes back in our integrated care clinic. We would then have her sample the detox food. We would talk to her about sauna therapy, about BEMA therapy. We'll talk about time-restricted eating and all of the things that we need to correct her metabolic condition. And we would follow these metabolic biomarkers that we follow in all of our patients like this. Now, if she gets on the program, when she starts the detox, we'll then see her every week, if not sooner. If she's in the sauna therapy, our sauna patients start infrared sauna. They do 5 days a week, so Monday through Friday, etc. And during this time, we typically see changes in blood pressure. I would expect her claudication to start improving within 2 to 3 weeks. The ABI would probably improve in maybe 3 to 4 weeks, if not sooner. And we would mark those changes, and we would point those changes out to the patient. And we would continue to carry her through. Instead of increasing her statin drug, we would show the reduction in her lipids and reduction in inflammation, and then we would reduce the statin drugs. And I've had patients who are bad smokers, who also are alcoholics. And when we put them on a nutritional detox regimen, we find that they actually are able to stop drinking and smoking fairly easily. And so we remove other toxins from the system. The body becomes less tolerant of other kinds of toxins, such as alcohol and cigarettes. Now, I'm not going to go out on a limb and say, hey, detox causes smoking cessation or rids one of alcoholism. We haven't done those studies. I'm just saying these are my observations. But I mentioned that in the setting of this patient smoking, yes, I'll tell her to stop smoking, but I'll really emphasize the food that she eats, or more importantly, the cessation of the food she should not eat, i.e. processed carbohydrates, processed other types of foods, cooked foods, animal protein, or dead animal flesh, as I call it. So we really put an emphasis on the removal and the nutrition of how the body's nourished first and foremost, and try to get her to make these improvements. If she's able to make these improvements over a period of 4 weeks, we're able to get a stronghold into her mind, her psyche, her taste buds, and she starts to see improvement, then I think it's going to help us a long way down. It doesn't mean she's going to be perfect all the time, but I think in the first 4 weeks, we can make a strong impact on her success and how well she's feeling, how well she's doing. Plus, we're able to wean some medications. We find that these patients start to do well. So I have a completely different approach than what's described in this review article. And I think it's important because what they said is that you want to, reduce overall cardiovascular morbidity, mortality. And the best way to do that is for the optimal nutritional intervention. Infrared sauna therapy does that. It works for peripheral arterial disease as well as coronary disease, and BEMA therapy works as well. In addition to the diet, we may give supplements on a targeted basis. Frequent people are vitamin D deficient, and we may supplement vitamin D as well. So I'm just going to give that little take. I think I probably talked too long. Let me open the floor to my colleagues and get your take on things. I know Dr. Floyd has a lot to say. He's seen a lot of these people with peripheral arterial disease. So whoever wants to take the floor next. If y'all see any questions that I've overlooked, let me know.
Okay, I'll say something here. Just from the practice of podiatric medicine, I mean, you really covered everything in detail, what needs to be done. One thing we look for, you do the diagnostic screening, but we're always looking for it at the earliest signs of the disease changes. So a lot of clinical evaluation we do to also look at things. And we share these with patients because I want patients to be proactive about their health, because when it comes to peripheral vascular disease, it's all about prevention or reducing the disease process, because it is a slow chronic disease that develops that way. But I instruct patients of doing things like you look at your fingers and toes, but one thing we look at is a capillary filling time. So by pressing on your nails, and you can count and see how many seconds it takes when you're pressing your nails, it'll turn white. And within 2 seconds, you want your nail to turn pink again. If it takes 5 to 10 seconds for those nails to turn pink, then that's a problem with reduced circulation to those areas. And then number 2, you always want to look at the hair. I have some patients come in and say, well, I have hair on my toes and I don't want hair on my toes. And I'm saying hair on your toes is a sign of excellent circulation to your skin. When you lose the hair on the top of your toes, or even the hair on your hands, if you have hair on your phalanges and your proximal to your distal to your knuckles, that's a sign that you have good circulation in those areas. And so we look for hair loss. Hair loss is a big sign that circulation is starting to decrease. And those are things you can see in the 30s and 40s and 50s early. As a sign of decreased circulation. So, that might be a risk for diabetes. When you see those things, some cardiovascular issues are probably going on also. So we want to really check those things. That way, when you can screen, but when you start getting abnormal tests, you know that you're already crossed the mark of intervention. And intervention process is tough, because when you're doing the revascularization, it's more, I call it, that's a 911 call. That's a Hail Mary in a lot of instances, because trying to reverse those symptoms are very difficult. There are, especially with patients who experience diabetes and symptoms of diabetes, we want to do their nutritional supplements you can take that will help improve that, like the alpha lipoic acid. We recommend people take anywhere from 600 to 1800 milligrams of alpha lipoic acid, up to 2 times a day. Because what that is a strong vasodilator. Opens up blood vessels and increase that blood flow, because the oxygen is a problem. The signs you mentioned earlier from the paper, the intermittent claudication, where you have pain, you walk 10 minutes, you have pain in your legs, and you have to take a rest, the pain goes away, you try to walk again, pain comes back. Pain is always a sign on exertion, as you mentioned, is a big problem. So you want to address that also. But again, in the paper, I think we should, and you mentioned it in your summation, that the diet and nutrition really needs to go first. You have to change those things. You have to stop drinking alcohol. When it comes to the smoking, nicotine itself is a strong vasoconstrictor. So if you have diabetes, if you have signs of peripheral vascular disease, and you continue to smoke, you're just making things worse. And so you will end up with amputations. And I'm a big proponent for those lifestyle changes, because amputations now in podiatry, we don't want amputation, because when you amputate it, then we're out of a job.
Yeah, no, that's well stated. Anyway, we're having a little fun in the chat, so you see some of my colleagues laughing there. But yeah, I think those are great points, especially, the hair on the toes and various things. But, we don't pay attention to a lot of those small things. And certainly, self-examination is really important. Really, the first examination, I've given talks in the past where I've said this, and I'll say that the most sensitive diagnostic and therapeutic tool in medicine in the future will be the meal plate. That's your breakfast, lunch, and dinner plate. And if you're consuming food that predisposes to peripheral arterial disease, then you're going to be in bad shape from the standpoint of being at risk for these diseases, whether it's coronary disease or peripheral arterial disease or cerebral vascular disease. When they did studies on autopsy teenagers, ages say 14 to 16, they found about 65%. And these are teenagers who died from cardiovascular, not from car accidents or traumatic injury. When they look into blood vessels, primarily in the heart and periphery, they see early signs of atherosclerosis in about 65%. When you get to the age of 22, based on studies done in the mid-50s in the Korean War soldiers, it's close to 80%, about 77, 78%. So you can only imagine when you get to 30, 40, and 50 years old, the prevalence of atherosclerotic disease is going to be very high. And so if you're living a standard American lifestyle, then you're putting yourself at very high risk of having some level of disease. So in that setting, with some level of disease, you're going to very likely be in a situation where, it's only a matter of time or only a matter of event. And just keep in mind, as I alluded to earlier, you can have moderate disease where there are no problems when you are, say, without any kind of increased stress. But let's say you injure your foot. Maybe you're in a car accident, or maybe you scrape your foot riding your bicycle or whatever. Then you have an injury where the body has to increase its ability to deliver oxygenated blood and the like to that extremity. In that situation, you're going to be in dire straits. So that's the stress that's going to be brought onto your system, where you have to have an amputation, maybe because the foot doesn't heal, the ulcer doesn't heal, or you may have to undergo revascularization emergently because the ulcer foot doesn't heal. And we see that a lot with diabetics. That's what diabetics are told to wear shoes all the time. They have peripheral neuropathies. They may not feel the tack or the nail or the rock, so they injure their foot and it gets infected. And the next thing you know, they have a gangrenous toe when, one point they felt good, the next point they have a gangrenous toe, and then they have to have advanced surgery. So be mindful before you get to that point and look at the lifestyle. If you're eating standard American diet, you're not getting out, you're not exercising, you're consuming some of the worst foods, and you have a family history of these things, then you're very likely have the disease. It just haven't manifested to the point where somebody wants to give you a pill or start a procedure. Any other thoughts from the gallery here? I think we all...
I wanted to say something. So claudication, we talked about it, is having the leg pain when we're walking. Many people don't realize, but that we talked about that word, but I didn't know if the audience was familiar with it. But walking a distance and developing discomfort, usually it's in the calves and having to stop that's a sign, that can be a sign of peripheral vascular disease. And this lady that we talked about, this patient, she seemed to be just a poster child for lifestyle and diet. Everything was wrong. The smoking was wrong. She's already had coronary artery disease and the bypass. And I think we don't, as physicians and practitioners, we don't impress enough on how important the diet is, because I'm sure her diet was very unrestricted with animal products, as you said, Baxter, and fried food and battered food and highly high carbohydrates, probably soda, sugary beverages and of that nature, but it was unrestricted, and that really was narrowing her blood vessels and causing more plaque and narrowing in her blood vessels. When it's early, when we have peripheral artery disease and it's early, walking is good because it can create collaterals, like where we're creating a bypass there, and the circulation can get around those blockages when it's early. So that's why you emphasize the walking and when we can. But sometimes there's other limitations. But I tell people about smoking. I say, everybody that has an amputation is not a diabetic, but smoking definitely can increase the risk for amputation and losing toes, feet, and legs. And I tell people that smoke, imagine yourself without a leg or a foot, every time you smoke. And, perhaps that has some impact in thinking about it, because most people would not want to be in a wheelchair without a leg or a foot. So, that we have to kind of visualize that.
Yeah, I think you're right. And I like your comments about her being the poster child for that lifestyle. I mean, and I don't know, and we see these people all the time. I mean, they come in and they've had all these issues, and I don't know, I would imagine someone's talked to them. I'm sure somebody may have whispered, stop smoking or whatever, but I get a sense that the emphasis is not placed on that. And I get a sense, you can look at this article. I mean, just look at this article. And we see from this article that that there's little to no emphasis on this lady making lifestyle changes. And even when they talk about their management, they talk about the drugs they're going to give. Of course, they do the Doppler studies, et cetera. But there's no discussion of intense counseling in terms of what you need to do. And this is a shortcoming, I think, in our medical approach to things. I mean, the New England Journal is one of the prominent medical journals. I mean, this is supposed to be the best of the best. This is the creme de la creme of medical treatment for somebody with advanced coronary disease, advanced peripheral disease. And I'm sad to say I give them a D. They mentioned lifestyle once, but I think that's a very poor management. I'm not saying that these drugs haven't had any scientific evidence, but this patient has systemic vascular disease. Just saying for coaching on smoking is not enough. She needs to be told to stop immediately. She needs to be told that she needs to drastically change her diet. She needs to be put in an intense nutritional regimen. You need to control her food first and foremost intensely for a defined period of time. The evidence of this is shown in the medical literature. And so that's the type of intervention that this patient needs. That type of intervention not only has the benefit of the actual effects of the food itself, but it has an impact on the psychology of the patient in terms of making her understand that what she eats has to be extremely pristine, extremely pure, and she must be very intentional about what she puts in her mouth, and more importantly, about what she excludes from putting in her mouth. And so that's the intervention that needs to be had, and in my opinion, is the first rate care. What's prescribed in this journal, not to be critical, is bush league medicine. I can't be more blunt than that, but it's not that revascularization, medical therapy doesn't have a place, but these things need to be at the very end. And she should have been in some kind of an aggressive intervention 5 years ago, where she had a bypass 6 years ago when she had a heart attack and bypass surgery. All of this would have been, done away with. Tex Houston 7 asked about treating this with a Beamer. Dr. Floyd, do you want to talk about that, or you and Pam have a lot of experience with Beamer?
Yes, Beamer is an option, but at some point it just depends on where you are in the disease process. You want to, again, give yourself the best chance for Beamer to work, but Beamer is a good option for increasing microcirculation. I think doing even adding to that chelation therapy, chelating those arteriosclerotic plaques, which in the larger vessels and larger arterioles has to be addressed also. Beamer really helps the circulation to the tissues, and it definitely has a benefit there. But the diet and lifestyle change, making those small adjustments are huge. One thing Dr. Pamela used to always say is, one of the earliest signs, especially in men, one of the earliest signs of cardiovascular disease or peripheral vascular disease is erectile dysfunction. So when we see young men in their early, late 30s, early 40s, and they're starting having erectile dysfunction issues, first thing you should do is call your cardiologist. You should look at your vascular, what's going on with your cardiac, because if those vessels are starting to clog up, then your coronary arteries can have problems, your peripheral arteries can have problems, and we can't leave out our brain because memory loss, confusion, those symptoms, because you still have that microcirculation in your brain that's there, because the arteriosclerotic plaques don't discriminate. They will go where they go.
Yeah, that's a great point. Erectile dysfunction is a form of peripheral vascular disease, and it can be considered a form of peripheral vascular disease because, like you say, those are like the so-called canary in the coal mine. But you mentioned chelation therapy. I was remiss in mentioning that. Chelation therapy and as well as ECP therapy can be beneficial for people with coronary disease and angina, but also peripheral arterial disease. And even the so-called mainstream allopathic medicine, they consider it a class 2B, both of them a class 2B indication for the treatment of people with intractable angina. And so I remember being at I think it's a ACC conference when, it was mentioned, and the presenter was saying, yeah, believe it or not, ECP and chelation therapy, the 2B, it acted like it was something strange, but they're very effective therapy, and so it's also another option for this as well. Somebody mentioned getting calcium scores early is a good way of screening. This patient, it would apply to somebody with peripheral vascular disease, but who don't have a diagnosis of coronary disease. This patient already had a diagnosis of coronary disease, had bypass surgery. So I'm not sure if a calcium score would be helpful here, but certainly in the general sense it would be. So, anyway, so that's our take on this.
Yeah, one additional thing I want to mention about the Beamer, just to clarify, Beamer is more of a wellness tool for people who want to, you want to maintain, get some stability when it comes to diet, nutrition, lifestyle, but maintaining wellness, that means that you want to maintain your level of circulation throughout your body, that you want to promote healthy options is how we use it. And I think is the most effective way to use it. It's not a cure-all where it's going to solve a problem. It can solve problems, but you want to use it as a way to maintain optimal health, to improve your health, to improve circulation, because that's what aging, I think, the biggest issue with aging or getting old is a reduced circulation over time. So the more your circulation reduces over time, the more symptoms and problems and conditions that we put diagnosis codes on or labels on, we tend to have. So Beamer is a good tool for that, and that's kind of how it's the most effective way to be used.
Yep. I agree.
For pediatrics, because I think sometimes, when we talk about topics like this, we don't think of it as being pertinent for the children. But as you mentioned, Dr. Montgomery, when they've done autopsies on children who've had accidents, they found evidence of atherosclerosis in these children. And so, especially now, I think it's important that we take heed to this because we're seeing more children with high blood pressure. Now we can change their lifestyle in just a little bit and it will come down, but it's very common now for me to see children come in and their blood pressure is elevated. And it's not just from being nervous at the doctor's office because it's multiple visits that the blood pressure is elevated. And that's usually in the teenagers. And also, as we've talked about before, their lipid panels are also elevated, which didn't happen so much about 10 years ago. But now, as our standard American diet changes, those numbers are also elevating. So, the children are really close in line to having issues a lot earlier in life. I mean, in this example, this lady is 50, 60 when she had this second event. But, if we keep moving in the direction that we're going to start seeing these episodes a lot earlier because, as Dr. Atkins said, most people can do well because they'll form collaterals. And I think that's why children do well, even though some of the vessels are narrowed and blocked. They still run. Children run everywhere, and that's a good thing. So they keep those collaterals going. But as they get older and are not as active, and also they've probably used up all the space, now we start running into roadblocks, and we'll start seeing some issues. It may present differently, but same thing. Cardiovascular disease on some level in younger people, I feel, unfortunately, is coming if we don't start emphasizing lifestyle changes earlier.
Yeah, I think that's right on, and we really, these diseases do start in kids, even though, like you say, they have some reserve and they don't manifest symptoms as early. But these are diseases of the children. They just manifest when they're older adults, and it's something that again, it starts with the lifestyle, and at some point the mainstream medical community maybe will wake up to the fact that lifestyle needs to be the emphasis of this. That needs to be bold. It's the main intervention. It's the main intervention early on. It's the main intervention even when you have symptoms, and even in the acute setting. We presented even on this channel how lifestyle intervention, even with somebody who has to have emergent surgery, et cetera, has the potential to improve outcomes even in the OR, the ICU, the ER, et cetera. So these aggressive nutritional interventions can have an impact and should be the emphasis at every point, whether it's the primary emphasis or co-emphasis of another emergent intervention. It needs to be a big part of the intervention. And at some point, we will wake up to this. I don't know when, maybe another 100 years, but anyway. But thanks, guys. It's been a great show as usual. It's good to have the whole team back. I think it's the first time we had the whole team back. So I never took all the pictures out. So I figure we'd all be back at some point. But anyway, thanks for being here, and I look forward to seeing you guys next week. We'll be talking about atrial fibrillation next week. I'll post that show, and then I'll see you guys backstage, and then we'll talk about other shows. So I'll see you backstage in a couple of minutes. Well, again, everybody, we have another, discussion on, a health condition that really should be treated with lifestyle intervention. And I really think that it's something that we should take to heart. This is just one health condition, but as you can tell from the article, from the presentation, it's linked to other health conditions, other cardiovascular events. It's related to cardiovascular disease, heart attack, and stroke. It's also related to diabetes and high blood pressure. It's also related to obesity and other metabolic problems such as diabetes. So the body's intertwined, and these metabolic diseases are really all one health condition that's a problem. So we have to be mindful of that. And really, there's a fundamental solution that needs to be considered. And that, of course, is your lifestyle. So again, thank you for joining us tonight. And again, give us a thumbs up if you like what you saw. Please take time to subscribe. And of course, share this with friends, with loved ones, or just share it in general. And don't forget to hit the notification button so you can hear about future stories. Until next time, keep it fresh, natural, and live.